everyone, welcome back to Karlee's Farm. Today we're going to talk about drugs used to treat hyperlipidemia. So the first and most common group of medications used to treat high cholesterol are the HMG-CoA reductase inhibitors, also known as the statins. These group of drugs inhibit CoA reductase, which is the very final rate-limiting step in the production of cholesterol in the liver. Now, when the production of cholesterol is reduced in the liver, the body knows that it needs more cholesterol, and in an effort to do that, it increases the LDL receptors on the hepatocyte. So by increasing LDL receptor production, the body can then accept more cholesterol from around the body to uptake into the liver. These drugs are things like atorvastatin, simvastatin, very, very commonly prescribed medications, and their side effect profiles reasonably safe. However, they have been associated with liver function abnormality and liver function test elevation, but most importantly, they have been associated with myopathy or muscle pain, weakness, and in very rare cases can cause rhabdomyolysis, which is where there is actual breakdown of the muscle. They can also cause GI upset, and as I said before, they're very common and they are the first line therapy. The second group, or the second drug that I want to talk about, there's really only one drug in this group, is ezetimibe. So ezetimibe inhibits intestinal absorption of cholesterol. So cholesterol that comes into the gastrointestinal tract in the small intestine is absorbed via a transporter called NPC1L1. So cholesterol is popped into this transporter, and the transporter takes it across into the cell or into the body. And ezetimibe inhibits this transport across that membrane. The third group are a group of medications called the fibrates. The fibrates have an interesting mechanism of action in that they activate the PPAR alpha receptor, which is a nuclear receptor and therefore responsible for a change in the expression of different target genes. And so there are a few different effects of fibrate therapy. Most predominantly, they reduce triglycerides and increase HDL. However, they do also have some effects on LDL. They are fenofibrate and gemfibrozole, so they've got fib in them, which is how you can sort of guess what class those drugs are in. Their side effects, they're again fairly well tolerated, but their side effects also include GI upset. And these drugs are also known to cause a myopathy and rarely rhabdomyolysis as well, particularly when they're used in combination with statins. So that combination of drugs is not recommended as standard therapy. The next group are a group that are not used particularly often in practice. These drugs are bile acid resins. And so, as you know, for cholesterol to, move around, it needs to be bound to something. And bile acid is how cholesterol moves through the gastrointestinal tract. And so if we give a bile acid resin, it essentially this resin will bind to bile acid, which inhibits the reabsorption of cholesterol from the gastrointestinal tract. Now, these drugs aren't used very often in practice because not only do they does it stop cholesterol from being reabsorbed by binding to bile acid and stopping it from being reabsorbed, it also can inhibit the absorption of fat-soluble vitamins and some other medications. So it's a little tricky to administer to people who are on other medications because it can interact and prevent their absorption. And the final group are a sort of a new kid on the block in terms of cholesterol therapy, and they are the PCSK9 inhibitors. So these guys are expensive. They are a monoclonal antibody. There's a couple of them on the Australian market now. And what they do is what So PCSK9 is a molecule that binds to LDL receptors and causes LDL receptor destruction. And so what the PCSK9 antibodies do is they bind to that molecule and prevent it from binding to LDL receptors and therefore preventing LDL receptor degradation. So they basically allow more LDL receptors available for LDL binding. Because they're monoclonal and they're expensive, there's limits to who can have them, and so the PBS has very strict rules around which patients can access these medicines, but they are becoming more popular in Australia. They're given via injection, so they're not a tablet, and they're most commonly prescribed for familial hypercholesterolemia that is not able to be adequately managed on other therapies. And that's all of the medications that we currently have to treat hypercholesterolemia. Thanks for joining me. See you next time.